Good evening, ma'am. I just wanted to make sure that this is hall number 4. Hello.
Good morning, ma'am.
Good evening, ma'am. This is hall number 4, right?
This is hall number 4.
Yeah.
This is hall number 4, ma'am.
Yes. I am the first presenter with the.
You are faculty paper 3-1.
Yes.
Yeah, please wait.
Yeah. Okay.
That's one, sir. സുനിൽ സാറിനെ വിളിക്കാം. സുനിൽ സാറിനെ വിളിച്ചിട്ട് ഏത് ഇതാ ഹോൾ 3 ആണ്. സുനിൽ സാറിനെ വിളിച്ചിട്ട് ഹോൾ 3 ജോയിൻ ചെയ്യാൻ പറ. ഒരു ജഡ്ജിന് കയറാൻ പറ്റുന്നുണ്ടെന്ന് പറ. Good evening all. Pushperi College of Dental Sciences is delighted to host the fifth Triple O Conclave. This is a scientific paper presentation, session 10, hall 4. It's my privilege to invite the chairpersons for the session, Dr. Repan Cheria, Professor and Head St. Gregorius Dental College, Kodamangalam, Dr. Jubin Thomas, Professor and Head, Malabar Dental College, Edapar. I invite you, sir.
Thank you, ma'am.
Dr. Jubin. Dr. Jubin. Let's wait for 2 minutes for Dr. Jubin to join us.
Sure, ma'am.
In the meanwhile, shall I confirm the participants? Faculty paper 3-1,
Yes, I'm here.
confirmed. Faculty paper 3-2. Faculty paper 3-2. Faculty paper 3-3. Faculty paper 3-4.
Yes.
Noted. Faculty paper 3-5.
Yes, ma'am, I'm here.
Yeah, noted. Faculty paper 3-6.
Yes, ma'am. I'm here.
Noted. Faculty paper 3-7.
Yes, ma'am. Present here.
Yeah, thank you. Faculty paper 3-8. I repeat, faculty paper 3-8. Faculty paper 3-8. Faculty paper 3-9.
Yes, ma'am, I'm here.
Yeah, noted. Faculty paper 4-0. Faculty paper 4-0. I invite Dr. Jubin Thomas, the chairperson, Professor and Head, Malabar Dental College, Edapar, to this session. Dr. Jubin. Dr. Jubin.
Thank you, ma'am. Thank you so much.
Okay, shall we start the session? Dr. Epan.
Yes, ma'am. Yes, ma'am.
Okay, the paper presentation will be for 5 minutes, for which at the end of the 4th minute, we'll be giving the first instruction. And the last minute after the 5th minute also, we will be giving the instruction to stop the presentation. The next 2 minutes will be for discussion. So let us start the first presentation. Judges, please note, this is faculty paper 3-1.
Ma'am, I have shared the screen.
Yeah, we can see. Please start.
Is it visible? Is it on
Yeah, yeah. Please start, ma'am.
Yes. Am I audible?
Yeah.
A very good evening to all the respected judges and my dear colleagues. My presentation is on hand-off orientation of head and neck specimens, an absolute necessity for diagnostic accuracy. As we all know, every specimen submitted to the pathological laboratory is very unique, and this is very much true for our complex head and neck specimens. And the data indicates that 80% of the adverse events like the misdiagnosis or surgical margins reports fail due to miscommunications. Hence, careful delineation of the associated structures and determination of orientation of the specimen becomes very crucial as a part of the grossing, which include a triage area in the pathological laboratory, followed by the sampling and further orientation. So coming to this handoff orientation, it is nothing but the face-to-face meeting between the surgeon and the pathologist to review the surgical specimen characteristics. And it has a huge impact on the interpretation of the specimen and diagnosis. And if followed correctly, it helps in the correct diagnosis or treatment of the patient. And it hugely depends upon the proper handling and processing of the specimens of the tissues. And studies have indicated this handoff orientation has resulted in decreasing the risk of miscommunication errors. So this helps in obtaining an achievable specimen's turnover time. That is nothing but the time period between the receipt of the specimen to the reporting. So the number of days can be minimized by proper handoff orientation. This will help in the highlighting the anatomical components to identify the different levels of lymph nodes, identification of the proper surgical margins, and any area of concern that is important for the surgeon, and also to relocate the problematic areas. So basically, this handoff orientation include reliable and rapid transfer of the specimens, accurate identification and description of the original specimen, as well as the additional specimens from the same patient, and also recording the normal and the abnormal structures. So with the help of the surgeon, we can obtain a complete data of the biopsy specimens, and that includes like the area of the biopsy, any surgical nodes like the intraoperative nodes, which are of importance to the diagnosis, and any habit history, and the number of specimens should be labeled in different containers, and the completeness of the tissue submitted. For example, many of the times the surgeon sometimes submitted part of the tissue to one pathological laboratory and in to the other one to the other pathological laboratory. So it becomes difficult for the diagnosis if a representative area is not obtained. And any specific treatment procedures like the use of lasers or electrocautery, which have an impact on the microscopic examination. So basically, the accurate identification includes the multiple specimens if they are there from the same patient. They have to be labeled differently, and with the help of sutures or inking, and also this helps in identification of the anatomical landmarks. So the specimen has to be described in detail with the help of the surgeon, and also should be confirmed the area of the biopsy, the size and extent of the lesion, any shape and demarcation and the contour, the surface, like there are any verrucous lesions or there is a cystic lesion, whether it was a single or multiple lesions, and the nature of the specimen, whether it is a soft tissue lesion or a hard tissue lesion. So specimen photographs and radiographs also plays an important role for grossing. This, with the help of surgeon, we can delineate the extent of the lesion and also make necessary notes in the record. So some of the lesions which may have very importance of this handoff orientation is like verrucous lesions, which can be ranged from a simple squamous papilloma to a squamous cell carcinoma. So delineating the entire the extent of the lesion with the inking with the help of the surgeon will be very useful. And also oral cancer resection specimens, the marking with different inks to delineate whether it is an anterior margin or the posterior margin and the tumor proper. And the level of lymph nodes, which has a in continuity when it is submitted, with the help of the surgeon, it has to be oriented properly, and then removal of the specific lymph nodes, which will help to know whether they are positive or negative. And the lymph nodes, sometimes the same level of lymph nodes might have more than one lymph node. So the cut section where there is a tumor ingrowth can be assessed grossly. Some of the odontogenic lesions, which are usually well circumscribed, but the extent of the lesion where the bone margin has been cut and what is the area of interest for the surgeon becomes very important. And especially the odontogenic cysts, which are very important. Maybe the entire lesion may not be able to, the surgeon may not be able to submit in toto. So these findings should be taken from the surgeon and should be noted during the grossing. So hence, to conclude, the handoff orientation should be followed with a specific standard operating procedures. This will help in minimizing the wrong diagnosis, inappropriate treatment, or reoperations, or physical and emotional disaster caused due to any of these above reasons. And it helps in obtaining an acceptable turnaround time. Hence, it is recommended that every pathological laboratory need to follow standard or structured protocol for handoff orientations. These are my references, and thank you.
Over to Dr. Abraham for discussion. Over to Dr. Eben for discussion.
Yeah. Thank you, ma'am.
Thank you, sir.
Yeah. And just go back. What is unique in this? And what is your main heading of the topic was
Handoff orientation.
handoff orientation.
It's like handoff tool, sir, which is the basic need of the R is that there should be a proper communication between the surgical team and the pathological team.
Okay.
So this is the highlight that as we all still, most of us know the importance, but still there has to be a proper protocol to be followed in every pathological laboratory. So we should have a checklist for once we receive the specimens, although the surgeons are very busy, but it becomes very important to communicate with the surgeon or the clinician to get a proper details about the specimen, so that microscopic examination and reporting becomes easier.
You were discussing about the anterior and posterior regions, no? How it
Yes.
will make a difference? Can you just explain in while doing a grossing or going to histopathology? Like,
Sir, many a times either they put long sutures or short sutures to indicate whether it is an anterior or posterior, or they use different inks also, different colored inks. So the extent of the lesion, the margin, whether it is clear or it is whether the margin what they have resected is adequate or it needs to be reconsidered, that will help in delineating the entire structure.
my question is what makes difference in if, for example, you are an anterior portion and posterior portion of the specimen. If you separate it when you do a grossing, what exactly you can make the difference? You told like that. That is why I just asked.
So the in association with the tumor proper.
Okay.
So the extent posteriorly, whether the surgeon what he has resected, is it free of the tumor? So
Okay.
we need to, because once the specimen is out of the patient or the lesion, so it becomes a little difficult. Especially, it is more satisfying if it is before formalin fixation occurs. If this is practiced to interact with the surgeon and then get a proper orientation of the specimen.
Fine. Thank you.
Over to Dr. Jubin for discussion.
Thank you. It was indeed a very useful presentation. I totally agree with Doctor that we need to have a proper discussion with the surgeon as a pathologist.
Yes, sir.
Yeah, just the details what is given in the paper is actually not enough. I appreciate your efforts.
Thank you so much.
I don't have any questions.
Thank you, faculty paper 3-1. Next, I call upon faculty paper 3-2. Faculty paper 3-2. Faculty paper 3-3. Faculty paper 3-3.
Hello. Yes, ma'am. I'll be presenting.
Shall I confirm you are faculty paper 3-3?
Yes, ma'am. I'm
Okay.
Dr. Vibhuti.
Okay. Please share your screen.
Ma'am, can you see?
Yes, yes, I can see. Please start your presentation. Your time starts now.
Yes, ma'am. So today I'm presenting a paper, Radiolucent Mandibular Lesions, Diagnostic Pitfalls. Here I would like to present case series of 3 patients who presented clinically as jaw swellings and radiographically as multilocular radiolucencies. Case number 1, a 58-year-old male patient reported with complaint of asymptomatic swelling in the lower left back region of body of mandible since 1 year. History of extraction with history of extraction of 3-7 1 year back. Lymph node of left submandibular lymph node was palpable. Intraoral examination showed 4 into 2.5 centimeter in size of swelling in relation to 3-4 to 3-7 with vestibular obliteration and from 3-2 to 3-8. Buccal and lingual cortical plate expansion was present. On palpation, it was tender with well-defined borders and it was hard in consistency. OPG showed multilocular radiolucency from 3-2 to 3-8 with well-corticated borders involving body of mandible. Knife edge type of root resorption was seen in the involved teeth. Based on clinical and OPG findings, provisional diagnosis of ameloblastoma was given. Histopathological features showed unencapsulated lesional tissue composed of solid sheets of tumor cells with plentiful hyaline matrix. The cells showed pleomorphic nuclei and so intraosseous salivary gland malignancy was a diagnosis given. For confirmation, immunohistochemical technique showed positive expression of CK, P63 and calpunin. So final diagnosis of intraosseous myoepithelial carcinoma of mandible was given. Treatment, the patient was treated with local wide resection with tumor-free margin. So these are the few cases which reported myoepithelial carcinoma. So case number 2, 38-year-old male patient reported with a chief complaint of painful swelling and mobility of lower incisors in the mandibular anterior region since 2 months. There was habit of tobacco chewing. Intraoral examination showed soft erythematous gingival swelling extending from 3-2 to 4-2. OPG showed bone loss, vertical bone loss, as well as radiolucency associated with 3-2. This is the intraoral picture. Histopathologic details showed photomicrographs showing cellular connective tissue stroma with malignant cells which are spindle shaped, elongated, round in appearance, and arranged in fascicular pattern. But the lesion grew in size during subsequent follow-up. And on the basis of clinical and histopathological findings, segmental resection of anterior mandible was performed under general anesthesia. Malignant cells with cellular atypia in the form of nuclear hyperchromatism, pleomorphism, and abnormal mitotic figures were seen. So histopathological diagnosis of malignant spindle cell neoplasm was given. As spindle cell malignancies can be sarcomas or carcinomas, panel of IC markers were used to confirm the cell of origin. So pancytokeratin and EMA markers were positive.
Ma'am, last 1 minute.
Yes, ma'am. And markers for connective tissue and salivary gland were negative. Okay. So final diagnosis of spindle cell carcinoma were given. So treatment, wide surgical excision with or without radical neck dissection. So these are the cases previously reported. Case number 3, 56-year-old female patient complained gradually increasing swelling since 4 months. On examination, paresthesia was present on the lower lip. intraoral swelling extending from 3.3 to 3.6 with buccal cortical plate expansion. Surface was regular and smooth and size was 6.4 into centimeter. On palpation, swelling was slightly tender and hard in consistency. So this is a radiographic picture showing radiolucency associated with teeth. The CBCT showed buccal and lingual loss of buccal and lingual cortical plates. So diagnosis of benign nerve tissue tumor was given. Treatment based on the radiographic and clinical diagnosis, surgical excision was
Ma'am, your
done.
time is up.
Yes, ma'am. And excess tissue was sent for histological. Should I continue for some time, ma'am?
You may
Yes, ma'am.
please stop.
Yes, ma'am.
Dr. Epen, over to you for discussion.
Yes, ma'am. Is it your cases? You are from which college?
I'm from YMT Dental College, Navi Mumbai.
Okay. This cases is from your on dental clinic, your on dental hospital or dental school or
Yes, I just joined as a faculty.
okay, okay, ma'am. Okay. Okay. Can you just and the second one, what was your differential diagnosis? Second case, second, what was your differential diagnosis? Before going
It was 1 second. Yes. So in no, it was not second case. Second case is my will. So it was provisional diagnosis of ameloblastoma because of all the features were showing of
I think this is the
odontogenic
first
neoplasm.
case, ma'am. I think the second case. Yes.
Yeah, sorry. So second cell was malignant spindle so it was
My question, I'll repeat. What was your differential diagnosis?
yes, it was either connective tissue neoplasm or salivary gland neoplasm.
What made you to come to the conclusion for salivary neoplasm? What was why you thought it is a salivary gland tumor? It come putting into the differential diagnosis.
Because of the spindle shaped cells. Because of the spindle shaped cells.
Anyway, ma'am, no, I think it's all rare cases.
Yes, sir.
Okay, it's all rare cases, and well presented. Okay. Thank you.
Thank you,
Over
sir.
to you, Dr. Jubin, for discussion.
Good presentation, ma'am.
Thank you.
Ma'am, your topic was like diagnostic pitfalls, right?
Yes, sir.
What was you trying to say us with these three cases?
Because they presented as unilocular or particularly multilocular radiolucencies in the mandibular posterior region, and they were all of them were presented as painless swellings, and they were showing particularly of odontogenic neoplasm picture. Means it was showing a picture of odontogenic neoplasm, but they were found to be malignant neoplasms.
What was the diagnostic pitfall in that? Like,
Pitfalls.
okay, ma'am, but
Because,
whatever it is, these three cases are really good. I think you should
I
appreciate.
would like to intervene. I'm one of the authors.
I want to
Hello?
thank Dr. Sheetal ma'am for giving me an opportunity to present her cases.
Hello.
Yes, ma'am.
Hello. Yeah, just wanted to say a few words. Sir asked the question that what is the diagnostic pitfall. Sir, looking at the radiograph, it looked like, as Dr. Vibhuti said, it just looked like any odontogenic tumor. But from histopathology, it came out to be varied types of malignant tumors. So that was the diagnostic pitfall was on radiograph. That based on radiograph.
Based on the radiography, it could be like it could go wrong. That's what you meant, right?
Yes, sir. That was the objective. That was the objective, sir. And for the second case, as sir asked, what is the differential diagnosis? That is the malignant connective tissue tumor, because oral squamous cell carcinoma doesn't present this way. So that was the differential diagnosis.
Sir asked why you put it as salivary gland neoplasm.
Yeah, I was asking why salivary gland. That is why I just asked. Okay.
Dental cells usually it doesn't indicate it's a salivary gland.
Yes, sir. Yes.
Thank you.
So much.
Okay, thank you so much.
Next, I call upon faculty paper 3-4. Faculty paper 3-3, kindly stop sharing. 3-3, kindly stop sharing.
I stop sharing.
Yeah, thank you.
Thank you, ma'am.
Faculty paper 3-4. Yeah.
Yeah, am I
Please,
audible, ma'am?
Yeah, I can hear you, but I cannot see the screen.
1 minute, ma'am.
Yeah, it is. Yeah, it's.
Is it full screen, ma'am?
It's not full screen. Yeah, it's full screen now.
Am I audible, ma'am?
Yes. Please start. Your time starts.
Yeah. Good evening. The title is Unraveling a Solitary Gingival Swelling, a Unique Case Report. A 48-year-old male patient was presented with a chief complaint of swelling in the lower anterior gum region for 3 years. The lesion was slow growing and showed a rapid growth for last 2 months. And the patient had no history of pain post-discharge, and the patient didn't report any other relevant past dental or medical history other than kidney stone. And he had a habit of smoking tobacco for 20 years. On extraoral examination, we could not find out any relevant finding. On intraoral examination, there was a solitary swelling of 4 into 3 centimeter in size, extending from 4.1 to 3.6 region. And it was covering the occlusal surface and extending towards the vestibule and towards the lingual surface. And the surface of the lesion was irregular with erythematous areas. And we noted displacement of 3.1, 3.2, 3.3, and 3.4. And on palpation, the swelling was firm in consistency, non-tender. There was a bleeding tendency on palpation and grade 3 mobility of 3.1, 3.2, 3.3, and 3.4. And level 1B lymph node was palpable bilaterally, but still mobile, non-tender. On radiographic investigations, we could find out a diffuse radiolucency over the periapical region from distal aspect of 4.2 to mesial aspect of 3.5. There was another radiolucency in the periapical region of molar, and there was a related root stems also. And the blood examination find normal, and USG abdomen showed calculus in the urethra. And we got an incisional biopsy of 3 soft tissue bits, which were firm in consistency, irregular in color, with a provisional diagnosis of pyogenic granuloma, carcinoma alveolus, and salivary gland neoplasm. Histological examination of HND stain slide. On the lower view, we could see stratified squamous epithelium with a pseudoepitheliomatous hyperplasia. And we couldn't find any atypical features in the surface epithelium. And another lower view shows a group of cells within the stroma, and those group of cells were having indistinct cytoplasmic outline with a prominent nucleoli. The hypover view shows that these cells are having intermingled with basophilic calcifications and hyalinization. And another area shows the clear cells. There was also calcification in between these clear cells. The hyperview of the clear cell shows the clear cytoplasm with the prominent central nucleus. And these cells were PS positive, musicarmin negative, and Congo red negative. And we reached the differential diagnosis of clear cell odontogenic tumor, clear cell odontogenic carcinoma, MEC, or a metastatic lesion. And the tissue was insufficient to do the IHC, so we requested a repeat biopsy. By the time CBCT was taken, and we could see a radiolucent lesion with the radiopaque flex and displacement of 2. And the repeat biopsy was provided with 4 soft tissue bits. On examination of the repeat biopsy specimen, we could find out a group of cells with eosinophilic cytoplasm, and another area with a group of clear cells with a basophilic calcifications. This is the hyperview of the clear cells with the basophilic calcifications. The other group, their eosinophilic cytoplasm were distinct with a few calcific rings, and a few cells were showing nuclear pleomorphism. The hyperview view of the cells shows clear intercellular junctions.
Last 1 minute.
And the cells taken cytokeratin positive, P63 positive, low mitotic index, dimentin negative, and a clear cell variant of COT was given. It is a very rare neoplasm with the chances of malignant transformation. And many studies have shown that the classic appearance of COT may not be present in all cases. It is only present in 50% of cases. And you could see pigmented cell, Langerhans cell, and clear cells within the COT. And in our case, the clear cell variant of COT is a distinct entity with more aggressiveness and high chance of recurrence. And many studies shows that it needs a radical excision. So in order to conclude, in order to reach a diagnosis of such case, we need histopathology, advanced technique like IHC, and radiographic examination. So these are my references. Thank you.
Over to you, Dr. Epan, for discussion.
How many months before you come across this case?
So recently it came. Actually, the excisional biopsy is just now we planned. Only the incisional biopsy has done. Actually, I think. Yeah.
You're from which school? You're from which college? Dental college?
Kottayam, sir.
Okay, fine. Okay. This was a rare case, and you are presented extremely good. And keep it up.
Actually, the problem with this case was the first biopsy specimen was very small, and we couldn't make out the intercellular junctions in that. So we got little confused. So when the second biopsy came, the tissue was sufficient, and in that we could make out more number of features. Yeah.
Jubin?
Hello.
Yeah.
Over to you, Dr. Jubin, for discussion.
Hello, ma'am.
Yeah.
Hello, sir.
Yeah. Is there any relation between the what was it? Urinary stone? Something was there? No? Kidney stone?
Yes, sir. Actually, this lesions showed clear cells. So we
even before
were thinking about metastatic lesions also. We were taking, while we are taking the history, the patient told about the kidney stones.
Okay.
So then we went for a USG and other medical examination to rule out possibilities of any renal cell or renal carcinoma.
Yeah. All were clear.
Yes, sir. Yes, sir.
Okay. Did you check the parathormone level also?
No, sir, we didn't check.
Okay. Good presentation. Good one.
Thank you, sir.
Okay, thank you, faculty paper 3-4. Next is faculty paper 3-5. Next is faculty paper 3-5.
Yes, ma'am.
Yeah.
Can Dr. Indu unshare the screen,
I'll
please?
stop share, ma'am.
Can you see my screen, ma'am?
Yes.
Yes.
Am I audible? Is it clear?
Yes. Please start. Your time starts now.
Good evening, respected panel members. Today, I'm going to present an original research, which is titled MATLAB-based evaluation of expression of epithelial mesenchymal transition and cancer stem cell biomarkers in metastatic risk assessment of oral stem cell carcinoma. As we all know, more than 90% of oral cancer deaths are mainly due to metastasis. Therefore, early detection and treatment is very essential to minimize the complications. And there are two important mechanisms by which metastasis can occur. One is epithelial mesenchymal transition, and there is also a role of cancer stem cells, which is of concern to us. Also, routine histopathological examination of HLE and IHC stained slides manually executed by pathologists are generally time-consuming, labor-intensive task, involves subjectivity, and has got large inter- and intra-observer variation. Therefore, the aim of the current study was to assess the metastatic risk of oral squamous cell carcinoma by quantification of protein expression of EMT and cancer stem cell biomarkers using MATLAB software. So we try to evaluate the protein expression of EMT markers, mainly E-cadherin, beta-catenin, MMP2 and MMP9, as well as cancer stem cell biomarkers, that is CD44 and CD133, using MATLAB-based method. So the standard protocol for immunohistochemistry was followed for the 6 biomarkers that have been mentioned. So 20 cases each of metastatic and non-metastatic cases were taken, and we subjected them to immunohistochemistry for both the EMT markers as well as cancer stem cell markers. Then we captured the images using research microscope, and the images were stored in BMP format in a computer. The first step that we did was texture segmentation, which is mainly employed to identify the regions based on the texture. As you can see in this image, we have extracted the S shape using the texture segmentation tool of MATLAB software. Similarly, we also used a color segmentation tool wherein you can extract similar kind of objects into a group. And this was employed even in our study to extract the positive immunopositive cell. And coming to the results, so first marker that we chose was E-cadherin. So we tried to look at both the proportion and intensity of the immunopositive cells using texture and color segmentation. When the image was subjected to the software, we could segregate the area which was positive for tumor cells. We took 10 such areas under 200 magnification, and then we tried to count the number of immunopositive cells objectively using this tool. And then this was a result. We found that it was reduced in case of metastatic as compared to non-metastatic, which was statistically significant. Then we tried to look at the intensity scores, and even this was found to be, this was done using the color segmentation tool, and we found that it was reduced in the metastatic group as compared to non-metastatic. Similarly, even the beta-catenin immunoexpression using texture and color segmentation was done both for the proportion and intensity, and it was found to be significantly reduced in the metastatic as compared to non-metastatic. As we all know, EMT can render the tumor cells migratory and invasive, and this will facilitate the entry into the blood vessels, and this can lead to micrometastasis. So reduced or loss of expression of E-cadherin beta-catenin complex leads to aggressiveness, enhanced invasive potential, increased metastatic potential, and it mainly acts through the Wnt signaling pathway. Then we try to look at the MMP2 and MMP9 biomarkers, both for the cells as well as the stromal cells. We use the similar mechanism, and we try to extract the number of positive cells, both tumor cells as well as the stromal cells. We try to look at both the proportion as well as intensity, and we found there was a significant increase in the expression of MMP2 and MMP9 in the metastatic group as compared to the non-metastatic, which was statistically significant. So MMP2 and MMP9 are gelatinases or type 4 collagenases that mainly degrade collagen type 4 and the main component of the basement membrane and extracellular matrix, which plays a role in neovascularization. So whenever there is degradation of the basement membrane, it will facilitate the invasion and metastasis. So the next step that we did was for the CD44 and CD133, we did a similar kind of evaluation, and we calculated the proportion and intensity of immunopositive cells, and this was found to be significantly high in the metastatic group as compared to non-metastatic. As we all know, cancer stem cells constitute a limited proportion of cells that represent a phenocopy of the original tumor, and it has got unique potential to regenerate tumor by differentiating into different cell lineages, and therefore it mainly resists the radiotherapy as well as chemotherapy. So the limitations of the current study was mainly the quality of staining and images captured can affect the processing of the images. Therefore, it has to be caution should be taken while capturing the images. And the original contribution is mainly, this is the first of its kind where an objective tool has been used, especially the texture and color segmentation in MATLAB, to assess the protein expression of immunostained sections of EMT and cancer stem cell biomarkers, therefore minimizing the bias in assessment. So what we found was MATLAB was an effective tool for assessing the metastatic risk of OSCC. So these are the references. Thank you.
Over to you, Dr. Yupen, for discussion.
Can you just tell me once again the aim of this particular study?
Yeah, it was mainly to assess.
Yeah.
It was mainly to see the protein expression of EMT and cancer stem cell biomarkers using MATLAB software. So we did immunohistochemistry and we tried to evaluate these 6 biomarkers. This was a phenotypic evaluation that we did using MATLAB software. So routinely what we do is we do a kind of manual, or which is a semi-quantitative method of assessment for counting the number of immunopositive cells. But here we try to use the efficacy of a software, that is a texture segmentation and color segmentation tool in MATLAB software, which will help us in easy counting of the number of immunopositive cells, as well as it gives you the score of the intensity of staining that is obtained, because generally we just say mild, moderate, severe, intense staining. So here we will get an objectivity, and therefore it will reduce a bias in assessment of the.
Can you just tell me the result now? What was your result?
Yes, sir. We found that there was an decreased expression of E-cadherin and beta-catenin in the metastatic group as compared to the non-metastatic group. And we also found an increase in MMP2 and MMP9, CD44 and CD133 immunoexpression in the metastatic group as compared to non-metastatic.
Thank you.
Over to you, Dr. Jubil, for discussion.
Yes, ma'am. Yes,
yeah.
sir.
Which are the markers that tell you about the epithelial mesenchymal transition in this?
So it is mainly E-cadherin, beta-catenin, MMP2 and MMP9. E-cadherin and beta-catenin are the intercellular junction molecules, the markers, and MMP2 and MMP9 are mainly the collagenases, which they are mainly degrading the matrix. So they help in facilitating invasion and metastasis.
So you found that the MMPs are increasing.
Yes.
In a metastatic group.
We found MMP2 and MMP9 to be significantly increased in case of metastatic as compared to non-metastatics.
Okay, you have this MATLAB software.
Yes, sir. We have the MATLAB software.
Okay, did you compared it with the manual method, no?
Yes, sir. We compared with the conventional method and we got similar results. Therefore, we found that this was much easier for evaluation as compared to the manual, which is very time consuming.
Where do you belong to? Which college you belong to?
MS Ramaya Dental College, sir.
Okay. Fine. Thank you. Good.
Thank you, sir. Thank you.
Thank you, Dr. Soumya. Shall I call upon next?
Thank you, ma'am.
Faculty paper 36. Faculty paper 36.
Yes, ma'am.
Yeah.
Is my screen visible, ma'am?
Yeah, it's visible. Your time starts now.
Good evening, everyone. I am here to present a systematic review on effectiveness of Somital in the management of chemoradiotherapy-induced oral mucositis in patients with cancer. So we all know that. So we all know that oral mucositis is an undesirable side effect of chemotherapy and radiotherapy, where basically what happens is because of radiation and chemotherapy, there is release of reactive oxygen species from the basal keratinocytes, and there is attraction of chemoattraction of inflammatory cells to that site, which ultimately leads to the destruction of the epithelium, causing ulceration, and then there is super added bacterial infection which takes place at that particular site, which further complicates the condition. So WHO has given a gradation for the oral toxicity because of chemo and radiotherapy, which grade 1 is there is soreness and erythema. In grade 2, there is erythema and ulceration, but patient can still swallow solid food. In grade 3, there is extensive erythema and ulceration, and patient cannot swallow the solid food. Whereas in grade 4, any kind of nutrition or emulsion is not possible. So basically, oral mucositis is a condition where there is a lot of pain, discomfort, dysphagia to the patient, and because of this, scientists have come up with various drugs, one of which is Somital, for the management of this condition. So Somital basically it is a combination of 3 herbs, Vaccinum myrtillus, which is bilberry, Echinacea angustifolia, which is narrow-leaf purple coneflower, and Macleia cordata, which is 5-seeded plum poppy. So these 3 herbs they have combined together and they have marketed it as Somital, which is available in the form of powder, and when mixed with water, it forms a gel-like suspension which can be swished and spit, and the patient is free from the pain. So with this background in mind, our research question was that whether Semitol is effective in the treatment of chemoradiotherapy induced oral mucositis in cancer patients, and whether Semitol is effective in the prevention of chemoradiotherapy induced oral mucositis in cancer patients. So our aim was to compare the available literature on the efficacy of Semitol for the prevention and management of chemoradiotherapy induced oral mucositis in cancer patients. Our population was children and adults with any type of cancer who are undergoing chemoradiotherapy. Our intervention group was Semitol patients who received Semitol. Our comparator was either placebo or conventional therapy, and our outcome was reduction in chemoradiotherapy induced oral mucositis. We registered the protocol in Prospero with the following number. We searched PubMed, Scopus, Cochrane, Google Scholar, Liliac, and Science Direct using the mesh terms which are present here in different combinations without any language restriction and without any date restriction. We included studies where children or adults with any kind of cancer were undergoing chemoradiotherapy with no gender restriction. We included randomized control trials, clinical trials, non-randomized interventional studies wherever Semitol's efficacy was checked. And our exclusion criteria include articles using any other medication for management of chemoradiotherapy induced oral mucositis, and in vitro studies, animal studies, case reports, review articles, letter to editors were excluded. So this is the Prisma flowchart where finally we received 4 studies to be included in our systematic review. These were the data that this was the information that we curated. So the first table, this depicts the demographic details. So you can see there are 4 studies, out of which 3 studies included adult patients, whereas 1 was done on pediatric population. The majority of the participants were males, and 2 studies were conducted in Italy. 1 was in India and 1 was in Chile. This is a description of included studies. So among the 4 studies, in 3 studies, the primary outcome indicated that Semitol, there was a decrease in the oral mucositis from the baseline grade to the grade at follow-up. There was a clinically significant difference. And in the 4th study, the secondary outcome was that in all the patients who received Semitol, there was resolution of oral mucositis. Apart from this primary outcome, all the studies had secondary outcomes where there was reduction in pain, the mucosal erosions, bleeding.
Last 1 minute.
Yes, ma'am. They also checked the adverse events and systemic absorption. So all the studies proved that there was no adverse event to Semitol, and only in all the 3 studies there was no systemic absorption of Semitol as well. And this was the level of evidence. 2 studies were level 2, 2 were level 3. We also did risk of bias assessment, where 2 studies had low risk of bias and 2 studies has moderate risk of bias. So the reduction of oral mucositis could be attributed to the individual features of the components, like Vaccinum reticulus has mucus protection, Echinacea angustifolia has anti-inflammatory properties, and Macleia cordata has antimicrobial properties. And in previous systematic review also, it was found that Semitol was decreasing the oral mucositis and the number of lesions. The limitations of our study was that the number of studies were less and quantitative assessment was not possible because of heterogeneous data. So our take-home message. Yes, ma'am. Just conclude. Yes, ma'am. So Semitol provides a well-tolerated and effective relief from chemoradiotherapy-induced oral mucositis in cancer patients. Thank you.
Over to you, Dr. Epen, for discussion.
How many patients, how many trials you had? What was your number of cases?
So there were 4 randomized control trials, and 2 were just non-randomized interventional studies. The total number of patients, there were four studies, sir. 2 were randomized control trials, and 2 were non-randomized interventional studies. And across the 4 studies, there were 182 participants.
Can you repeat it? It is not clear, that is why.
Sir, so 2 studies were randomized control trials, and 2 were non-randomized studies. And across all the 4 studies, there were 182 patients.
How much was randomized and how much was non-randomized? What was, how much?
Two studies were randomized, sir.
Okay.
And 2 were non-randomized. Yes.
So what was the limitation? You were telling about the limitation of the study. What was the limitation of the study?
So basically, sir, the number of that was the first limitation. Only 4 studies have been done so far. And the second limitation was we couldn't do a quantitative assessment because the data was very heterogeneous. One study, the results were presented in percentage, one was in mean and standard deviation. So we could not arrive at a conclusive conclusion, like the quantitative assessment could not be done.
Right.
Yes.
Over to Dr. Jubin for discussion.
Hi. Hello, Doctor. You mentioned only 4 studies have been done about Samital. Hello.
Sorry, sir. Yes, sir.
Yeah. Did you say like only four studies were done about Samital?
Yes, sir. Yes, sir. With
Or
Samital, only 4 studies have been.
Or religion or gastrointestinal also?
No, sir. In oral cavity. Gastrointestinal, it has been done, sir.
It is okay.
Yes.
And what is the inference?
So inference is that Samital is reducing the oral mucositis from the baseline grade, sir. But we need a more substantial, because across all 4 studies, only 182 is the sample size. So we need a larger sample size to substantiate our results.
When was it introduced, Samital?
Samital first introduced in 2013, sir.
13. And even now only few studies are done.
Yes, sir. Yes, sir. And actually, this drug also is under clinical trial, and it has only received US FDA approval for trial, sir. It is not yet commercially available.
Okay.
Thank you, Dr. Rahul.
Thank you, ma'am.
Shall I call upon the next presenter, faculty paper 37? Faculty paper 37.
Yes, ma'am. Can I start sharing, ma'am?
Yes, please.
Shall I start, ma'am?
Please, your time starts now.
Good evening, everyone, and happy Holi and happy Women's Day to all. This is 37, and I'm presenting a soft midline swelling of neck in a 64 years old female patient who presented with the swelling of the mid-neck region of 1 year duration, and it was a progressively enlarging soft swelling. It was present at the level of the thyroid cartilage in the anterior neck, and it was centered a little towards the right and 1 centimeter below the hyoid bone. The catch point here was the swelling moved slightly with protrusion of the tongue, not much, slightly. On CECT, we found a subcutaneous enhancing mass, heterogeneous enhancing mass of 26 into 24 millimeter at the level of the thyroid cartilage. Multiple nodules were seen in the both lobes of the thyroid, and no additional lymph nodes or any nodes were seen elsewhere in the neck. Differential diagnosis, lots can be considered, but for this case particularly, we have to consider thyroglossal duct cyst, but there are multiple nodules in the thyroid, so we have to consider metastasis also. Both are like very opposite of each other. So what we did cyto. Cyto showed monolayers of polyhedral cells with pleomorphism, and it is additional thing is intranuclear cytoplasmic inclusion, very much suggestive of papillary thyroid carcinoma. There were some grooving of the nuclei, again suggestive of papillary thyroid carcinoma. So it was not merely a cyst. So it could be a malignancy arising from papillary thyroid carcinoma. In any ways, we have to do cyst trunk operation with total thyroidectomy and radioactive iodine ablation. Grossly, the lesion was a cystic lesion which was totally filled with some solid tumor, which was creamy brown in color. The thyroid gland was also removed, but multiple section serial sampling of about 54 blocks were made. No tumor was seen grossly or histologically. Histologically, in the thyroid gland, we saw only goiter-like features or chronic lymphocytic thyroiditis. In the lesion of the neck, we saw something tissue which was cystic in architecture, lined by single or 2 to 4 layer of stratified squamous epithelium, and a papillary tumor was seen arising from the cystic lining, which was papillary thyroid carcinoma, very much obvious. There was in the lesion was seen into the lumen, it was seen into the mural component also there, eliciting very prominent lymphoplasmacytic infiltrate with germinal center formation. This is the lining of the cyst, which appeared stratified squamous. Now, all the nuclear features of papillary thyroid carcinoma were seen: papillary arrangement, thin fibrovascular cores, orphan annuli nuclei, egg in basket appearance, then clustering of nuclei all held together, overlapping with nuclear grooving is seen at areas, and multinucleated giant cells were seen in the cores. IHC P63 was positive in the lining, negative in the tumor. Thyroglobulin positive in the tumor, negative in the lining. CD56 was done, which was negative in the tumor. So final diagnosis was made: papillary thyroid carcinoma arising in thyroglossal duct cyst. Thyroid gland showed only features of chronic lymphocytic thyroiditis. Hormonal replacement therapy was given after operation, and after 2 years, there was no recurrence. So thyroglossal duct cyst is common, but malignancy arising from thyroglossal duct cyst is just 1 to 2%. Most of the time it will be papillary thyroid carcinoma. In one report, it was reported as 80%, other it was 94%. So somewhere in 80 to 94%. Earliest mention was in 1911. Mean age is around 40 years. Females definitely are more commonly affected. There are two theories. One, it is a de novo, or it can be metastatic from thyroid, which has arisen in reached the thyroglossal duct. We ruled the later metastatic thing because there was no occult primary in the thyroid. There was no microcarcinoma in the thyroid. No signs of self-regression, because that is also one feature of thyroid, papillary thyroid carcinoma. So we ruled out all these things. So we favored de novo primary papillary thyroid carcinoma arising in thyroglossal duct cyst. Cystic operation is always the treatment of choice. If the age of the patient is more than 45, we go for thyroidectomy. If there is rapidly enlargement, we go for thyroidectomy. Invasion of structures, definitely. If neck nodes are done, if there are positive nodes on both sides, then we can go for neck dissection also. Overall survival is very good, excellent. It is 99%. Our recurrence is just 4.3%. So we need extensive clinico-pathological correlation.
Last 1 minute.
For diagnosis of such lesions. Most of the time, these are benign cystic lesion, but we cannot rule out malignancies. So cytological examination is mandate. So based on the disease process and age, we do thyroidectomy with neck dissection, which is added to cystic operation. These are the references. Thank you.
Over to you, Dr. Epen, for discussion. Over to you, Dr. Epen, for discussion.
Yeah, doctor.
Yes, sir.
Do you find any primary tumor in this particular case?
So such cases have been reported as papillary thyroid carcinoma in thyroglossal duct with synchronous papillary thyroid carcinoma of thyroid. So we cannot actually rule out which way it is going, because thyroglossal duct cyst and thyroid both are actually in the conduit of the same structure. So which way it is going, we cannot say. So they are reported as thyroglossal duct cyst with papillary thyroid with synchronous papillary thyroid carcinoma of thyroid. So such cases are reported like synchronous.
Second thing is, do you have done any hematological evaluation for this particular patient? What all?
Which? I didn't get, sir.
Hematological evaluation. Any findings in the hematological evaluation?
No, sir. No particular findings, but hormones like T3 and T4 were normal. TSH was raised and thyroglobulin was low. So that was also suggestive of Hashimoto thyroiditis, chronic lymphocytic thyroiditis. So that could be the reason for multiple nodules in the thyroid gland.
The last question is like, what is the hormone therapy suggested for the treatment?
So for lifelong, we give just iodine replacement. That's all.
Okay. Thank you. Good presentation.
Thank you, sir.
Over to you, Dr. Jubin, for discussion.
Doctor?
Yes, sir.
As dentist, what is the relevance of this topic to us?
Sir, the thing is, this was now, as a dentist, if we say now dentistry is not just related to oral cavity, it is spreading its legs like towards the neck and all. Another thing is thyroid is one of the malignancy which commonly comes into the oral cavity, mostly to the gingiva. Another thing is, when it comes to the oral cavity, it resembles, one is the scribriform adenocarcinoma of tongue, which is otherwise now regarded as polymorphous adenocarcinoma. So we have to be familiar with these things. So that's why I said.
What should be the ideal treatment for papillary thyroid carcinoma?
So papillary thyroid, yeah, it depends on, sir. Like if the lesion, it depends on the tumor stage. If it is like T1, T2, T3, which is totally in the thyroid gland, just thyroidectomy is enough. And it depends, like if it is like unilateral or bilateral, based on that we can do. When it goes to T4, after that we have to give radioactive iodine ablation, and hormonal therapy will go, like, because thyroid is gone. And thyroid, after thyroidectomy, we have to go for both.
In this case, we have removed entire thyroid.
Yes, sir.
Okay. Was it necessary?
Yes, sir. Sir, because even if it is, there is nothing in the thyroid gland, when we see this papillary thyroid carcinoma, even in the node or the thyroglossal duct cyst, so this papillary thyroid carcinoma, the removal of thyroid gland, it depends on the age of the patient. This patient was 64 years old female patient. So after 45 years, it is mandatory to remove the thyroid gland with the cyst trunk operation. Otherwise, just hyoid bone and that lesion is enough to remove. So age and aggressiveness of the patient, this lesion, it will dictate how to
How much of the
yeah.
In this particular case, you had done thyroidectomy. Total thyroidectomy has been done.
Yes, sir. Yes, sir.
Then the treatment you had given only iodine therapy.
Yes, sir. Radioactive iodine ablation was also done for the removal if something is remained for that. Radioactive iodine ablation was also done.
okay. Okay, doctor. Thank you.
Thank you, Dr. Deepak.
Thank you, ma'am.
Next, I would like to call upon faculty paper 3.8. Faculty paper 3.8. Faculty paper 3.9. Faculty paper 3.9.
Yes, ma'am.
Yeah.
Yes, ma'am.
Please start the presentation. Your time
Yes.
starts now.
Is it audible, ma'am? And it is
Yes.
very good evening to the respected judges here. So here I am to present on the review paper entitled as Non-Surgical Treatment of Ameloblastoma, How Close We Are. So ameloblastoma is thought to be derived from the odontogenic epithelium, and it is considered to be the second most common odontogenic tumor. And it holds a unique position because though it is benign, it is locally aggressive in nature. That is, it has got a destructive and an invasive nature. The existence of ameloblastoma has been proved even before from the Cretaceous period, that is about 69 million years old. But till now, the first therapeutic choice for the ameloblastoma is a surgical resection, and that too with a wide margins, so which ultimately results in the compromised quality of life. The role of adjuvant therapies like radiotherapy or the chemotherapy has been controversial or because of its unpredictable results. So this might be because of without identifying or targeting the specific mutation, or maybe because of lack of continuity in the molecular signaling pathways. So this indicates that for the past few decades, numerous gene dysregulation has been found in the literature. But in 2014, there is a breakthrough in the pathogenesis of ameloblastoma where BRAF mutation was identified in the ameloblastoma. So here we could see that this was a very breakthrough in the pathogenesis of ameloblastoma, where we could see that stimulation of an unknown growth factor stimulates or deactivates the BRAF mutation, whereby it takes the cell for proliferation through MEK and ERK pathway. So after this discovery of this BRAF mutation, there has been studies have come out with targeting this particular mutation. So here we could see that a study has been published in 2020-21. So where they have treated a pediatric case of ameloblastoma with a drug that is called as dabrafenib. So this is a drug which particularly inhibits the BRAF. So here we could see that a case of ameloblastoma, by treating this with a dabrafenib drug, we could see a tremendous bone regeneration without any surgical intervention. But here exists a pitfall, because here we could see that out of 521 cases, only 39 cases seems to show the BRAF mutation. So these are the works which we have done for the past few decades. And by this, we have also found that apart from the BRAF pathway in the pathogenesis of ameloblastoma, there exists few other pathways where the ameloblastoma takes the cell for proliferation and differentiation. So these are nothing but PI3-AKT pathway and nuclear factor kappa B pathway. So by looking at the literature, here we could see that there are three different downstream signaling pathways, that is the MAK pathway, PI3-AKT pathway, and nuclear factor kappa B pathway. So all these are controlled by the main switch over here, which we could able to see here. These are nothing but the neurotrophin and this receptor. So this acts as a main switch by controlling the other three downstream signaling molecules. And the expression of this neurotrophin and
androgen receptor has already been proved in odontogenesis. So any dysregulation in this gene, that is particularly the neurotrophin androgen receptor, can dysregulate any of the three pathways and might result in the ameloblastoma. So with this knowledge, we have also done the drug target interaction using the PanRex by combining with the biotechnology department. And here we could see that the dabrafenib, which is a drug which has been previously used in the ameloblastoma, is targeting only one gene. So this might be because the failure of this drug might be because of this. So instead of targeting a particular downstream signaling pathway, we have to target the main switch, that is all the neurotrophin receptor. So this is the another analysis, that is the string analysis, where we have seen the protein interaction. So here we could see that these are the neurotrophin receptors. So it has got a strong link or a strong protein interaction with the PI3 MAP pathway and the nuclear factor kappa B pathway. So with this, we can understand that. Yeah. So with this, we can understand that the neurotrophin has got a strong interaction with the three downstream signaling pathway, that is PI3, nuclear factor kappa B, and the MAK pathway. So with this, I just want to conclude that the ameloblastoma, which is a aggressive odontogenic tumor, which also needs a wide surgical resection, so can be silenced or can be treated by silencing the main switch, that is the neurotrophin androgen receptor, so that we can manage the ameloblastoma without any surgical intervention. And yes, we are not very too far. So once this research has been translated into clinical side, I believe that the ameloblastoma can be managed without any surgical intervention in future. So these are my references. Thank you.
Over to you, Dr. Ipen, for discussion.
What could be your drug of choice for this particular treatment?
So the drug should target the neurotrophin and its receptor, sir. So this is a very basic study, because we have found out that the neurotrophin is only having the control over the other three pathways. That is the BRAF pathway, which has already been proved in the literature. So a drug should be designed so that it controls, or it activates, or it stops the activation of the neurotrophin, sir.
Any literature? Do any literature suggest any drugs?
Sir, it has to be it has been taken into the clinical side. It is just a very beginning. So the study is very in the initial stage, sir. So it has to be translated, sir. So for that, to confirm that we have done the.
Sir, being a co-author, I can answer this question. Sir, actually, the two drugs which has been so far tried is dabrafenib and taratanefib.
Exactly, sir. So my question is, the first drug, the dabraxine drug, how many percentage and any clinical trials has been done, and how many percentage that was been successful, sir?
Sir, they have tried it with the 6 cases. This was the very first study after 2014. They came out with identifying this BRAF mutation. They clinically translated it, and they tried this with the 6 patients, and all the 6 patients were pediatric patients.
Okay, sir.
So that was conducted in Israel, and all the 6 patients showed positive response for this treatment.
Okay, sir. Okay. So this do you have any difference between the first drug and second drug in the pathways, affecting the pathways?
But our question is, studies, not all the ameloblastoma 21 cases. Pardon, sir?
My question is dabrafenib and the other drug which what you are told, does it affect the same pathway, or
it is successful only in BRAF mutation pathway?
Yeah. Okay. Fine.
So what we are trying to say is, you have to go much more further, and you have to target the main switch, that is the regulatory switch of this BRAF mutation and other 2 pathways, which is AKT and nuclear factor kappa B pathway.
Okay, sir. Okay. Thank you.
Thank you.
Doctor. Hello.
Dr. Jubin. Yeah. Dr. Jubin, how are you?
Yeah, sounds like very interesting topic. First time I'm hearing about the pharmacological management of ameloblastoma. And it is really interesting. Good.
Thank you, sir.
Thank you.
Shall I confirm your name, please? Faculty paper 3-9.
This is Dr. Yoita Prabhunath and Dr. K.K. Sri Chintu. We are both authors and co-authors.
Okay,
Yes, thank you.
Okay. I just want to confirm that. Thank you.
Okay.
Yes, ma'am. Thank you. Thank you.
Shall I call upon faculty paper 40?
Yes, ma'am.
Yeah. Please start sharing and screen.
Is screen visible, ma'am?
Yes. Yes.
Okay.
Your time starts now.
Good evening. I'm presenting a case report titled Diagnostic Dilemma in Focal Reactive Growth Occurring in the Palate. We all know hyperplastic lesions are common in gingiva and mucosa, which throw upon a tight spot to clinician due to close imitation in their clinical appearance. Etiology could be due to local or systemic factors. The common pathogenesis pathway could be because of chronic trauma followed by inflammation, granulation tissue formation, endothelial cell proliferation, which lead to chronic inflammatory cells, later fibroblasts. So that term reactive hyperplasia is quite commonly given. Here I present a case report which has and the accepted classification being focal fibrocytopenia, pyogenic granuloma, peripheral ossific fibroma, and peripheral giant cell granuloma. They represent the same lesion at the different development. Here I present a case report which reported to a 68-year-old female patient reported to our center with a complaint of growth in the right maxilla, which increases in size over 6 months. Intraoral examination revealed an pedunculated growth involving the palate and maxillary gingiva with respect to 1.6 and 1.7. 1.6 was extracted long back, measuring approximately 2 to 3 centimeters, forming consistency. Overlying mucosa appears normal in color and not associated with pain, ulceration, or bleeding. A faint linear pigmentation was noticed around the midline. She also reported that she visited a dentist earlier 6 months ago, and diagnosis of epulis was made and a treatment was given for the same on the same route. Patient deferred a treatment for further 6 months. Intraoral periapical radiograph revealed a mild erosion in the edentulous area. A CT revealed an enhancing well-defined lesion with areas of mild bone erosions underlying the alveolar process. After routine hematological examinations, histopathological examination was performed. So microscopically, the lesion cells were scattered throughout the fibrovascular connective tissue of stroma, composed of both epithelioid and spindle-shaped cells, lacking arranged in nests, cords, and short fascicles. And these lesional cells were showing eosinophilic cytoplasm and central round nuclei and vesicular chromatin and prominent cherry-red nucleoli. See, after many IHC markers, S100, HMB45, and melanine were turned out to be positive. So it showed a cytoplasmic immunoreactivity for these things. A final diagnosis of amyloidic melanoma was achieved. So further, after PET-CT revealed an enhancing soft tissue lesion in the hard palate with increased FDG uptake and also subsequent metabolically active right level 1 and 2 cervical lymph nodes were observed and was considered metastatic. Patient received underwent maxillectomy with modified neck dissection. Reconstruction was done using the free fibula graft. Adjuvant radiotherapy was given post-operatively. This is the resected specimen and the lymph nodes. Further, since the patient was a gynecologist and she was very keen on going for the complete treatment to get rid of at least reduce the burden since it was advanced metastasis was there. So we underwent a mutation analysis was done for c-KIT, RAS, and BRAF mutations. c-KIT and RAF mutations were turned out to be positive. So positivity were noticed for c-KIT and BRAF. So patient received adjuvant therapy and a specific RAF kinase and KIT inhibitors. Moving to the discussions, primary mucosal melanomas occurring in the head and neck areas is a rare entity. Weber was the first person to describe mucosal melanomas. Over 90% occur in the skin and only 1% are known to occur in the oral mucosal surfaces. Interestingly, among this 1%, mucosal amyloidic melanomas occurs only for 2.3% of all the reported melanomas. The etiological and risk factors remains obscure. The mucosal melanomas histopathologically show undifferentiated and have a varied cellular activity. They represent a myriad of cells morphologically ranging from epithelial, spindle to mixed to undifferentiated cells. The term amyloidic melanoma is used for both amyloidic melanoma with no pigmentation and lesions with minimal residual pigmentation. This poses a diagnostic challenge. So a panel of IHC is usually used to establish the diagnosis. Why? Because the pigmented melanomas is easy to diagnose, amyloidic melanomas, and moreover, they have more poor prognosis and aggressive lesions, and a rare entity. So morbidity and mortality associated with such lesions are also high. So in this particular case, there was a recent advances like the role of targeted therapy was analyzed.
Last 1 minute.
This helps. The targeted therapy not only helps in identifying the this IHC panel of IHC markers not only helps in targeted therapy, and also which step the mutation analysis has gone wrong. So even though there is a very etiology pathological process, the mutation analysis as widely well used in this case will help in the process. And this target, this model was put up for the mucosal melanomas, as rightly said by Sir William Osler, as is your pathology, so is your practice. What the pathologist thinks today, the physician does tomorrow. So the domain of genetic analysis falls in the court of pathology. So we can involve in the patient management, which can is a new paradigm shift in the treatment analysis. So the present case highlights the need for clinician to be aware of differential diagnosis of reactive growths, and this patient later sued a primary clinician, which the liability was in a couple of lakhs because it was considered as a medical negligence. So in addition to this case highlights the importance of logical approach to diagnosis and better patient management. So the role of pathologists in treatment planning, especially as we mentioned in target therapy response for tumor anti-cancer drugs, will holds it good. So in the comprehensive treatment. Thank you.
Over to you, Dr. Epen, for discussion.
What is the prognosis of this particular case?
This, sir, she did well for 2 years. In second year of second COVID wave, we lost her because of the COVID complications, sir.
What was the differential diagnosis? They should have put this in this case, differential read.
So first we thought fibrous lesions and neural tumors, sir. We were confused with both fibrous sarcomas and neural tumors. And honestly speaking, we were confused, and we systematically went with a couple of IHC markers. Finally, SLR came positive, and then we went to this cocktail of melania and HMP45, sir.
Usual prognosis of this case?
Sir, sorry, sir?
Usually prognosis of this particular type of cases. Can you just tell me the prognosis of this case? Usually, commonly, how much?
No, this particular case or general, sir?
In general.
So the literature says less than 5 years, sir.
Okay, fine.
Over to you, Dr. Jubin, for discussion.
How did you find that it's a melanotic melanoma? Like, what made you think like that? Like, because of the epithelial cell?
No, sir. First, we never thought as melanotic melanoma. It's only because of the cocktail of IHC markers when it turned out to be positive. After IHC only, sir.
So you must have gone through all the differential diagnosis of
exactly, sir. It was a panel of IHC markers we poured on this tumor. So as I mentioned, madam was a professor and head in one of the government institute in Bangalore. So she was also a little worried about it. And in fact, we took one of the help from Tata Memorial head, Shanta Kumari madam. She was involved in the panel to finally diagnose this.
Thank you.
Thank you, Dr. Deepak.
Thank you.
Shall I call upon faculty paper 3-2 again? Shall I call upon faculty paper 3-2 again? Final call for faculty paper 3-2. Shall I call upon faculty paper 3-8? Faculty paper 3-8. Final call for faculty paper 3-8.
Yes, ma'am. Yes. Hello, ma'am. Yeah.
Yeah. Please start your presentation.
Yes. Yes. Good evening, everyone. Today I shall be presenting a case which was seen in the in our college. There was a patient, 38 years old, by name Rohit, who reported to our college with a complaint of swelling on the right side of the cheek. The swelling was mild with not much of. Then we checked for the past dental history and medical history and did the clinical examination. There was no abnormality as such detected that we could take notice of. Then on extra oral exam, swelling on the right side, which was tender and it was kind of soft in consistency, nothing more than this. It was a very slow growing lesion, like it was there from almost a year or so, and it grew very slowly, and it came to a size which is noticeable now. The color of the lesion was almost similar to the skin color. It was around 3 centimeters in size. And on palpation, we felt it was more soft, not firm or something. and there was pain. That was the main reason why the patient reported to our hospital. Then we thought it could be a pleomorphic adenoma, and we included even Wathin's tumor as a differential diagnosis. Then we asked the patient to undergo for biopsy and do some CT scan and all. And also some of the surgeons were like, we will do the superficial parodectomy and take a specimen and detect what the lesion could be. And we received a specimen and a gross examination was done. The tissue what we received was fibrofatty in nature, measuring around 5.5 to 3.5 to 1 centimeters. Then the cut surface showed kind of yellow fatty region, which was like, we could feel that it is more like a fatty tissue. Then a histological examination, we saw that it was mainly a composition, not of a salivary gland parenchyma, but of adipocytes. It was well demarcated. It did have a capsule lining, and it showed the presence of mature adipocytes within them. And there were small septae that were dividing the serous acinis of this parotid duct. They were lined by cuboidal cells with no major cellular ertapia. Blood vessels were also seen. There was no evidence of granulomatous region in this area. Hence, we came to a diagnosis of lipomatosis of parotid gland. Now, the reason why I'm presenting this particular case is it is very rarely encountered lesion of lipomatosis of parotid gland, and also the fact that usually it is bilateral in nature, but here we had only swelling related to one side of the cheek, that is on the right side of the cheek. Plus, it was usually the lipomatosis of parotid gland usually is seen in the superficial lobe of parotid gland, but here we saw it on the lower, kind of near to the lower lobe of the parotid gland. So this was the case presentation. Thank you.
Over to you, Dr. Epen, for discussion.
In general, what was the percentage? Right, you told it is rare. How many percentage in general?
Around very relatively rare to approximately 3 to 4% is what is recorded in the literature.
Is it
for dentists,
is it a male patient?
Lipomatosis of salivary gland, or else most of the time it is a male patient, sir. 38-year-old male patient.
Over to you, Dr. Jubin, for discussion.
Hello, ma'am. Was the lesion completely inside the parotid gland? Could you find a histological relation between this tissue, the lesion tissue and the parotid gland tissue?
Not much, sir, except for the septae that was dividing. We did, actually, I couldn't get the radiographic features for the presentation, but the patient has a CT in which there was radiolucencies with the interspersed septae. So that and the clinical examination, not much of lesion visible. It was only the external lesion, and TMJ was intact, and it was more coinciding with the parotid gland. That's why we came to conclusion, and along with the general pathologists in our college, we kind of came to this conclusion. So,
what I'm asking is, like, how did you differentiate a lipoma or liposarcoma, whatever, from this lipomatosis?
So mainly, usually lipomas are also kind of are in the differential diagnosis, but here we are seeing serous acinis also present along with the adipocytes. That is how we could know that it is a lipomatosis.
The picture? Was it there in the picture?
In one, it is there, sir, but not like you could see some of the acinis here, not all. It was just recently seen case in our college, sir.
Here comes the end of this session.
Thank you, ma'am.
Pushperi College of Dental Sciences would like to acknowledge you for chairing the session 10 Hall 4 scientific paper presentation. Dr. Epen Cherian, kindly receive the certificate as a token of our gratitude and appreciation.
Thank you. Thank you, ma'am.
Welcome, sir. Dr. Jubin Thomas, kindly receive the certificate as a token of our gratitude and appreciation.
Thank you so much. Thank you.
Yeah, welcome, Dr. Jubin. So let us wind up the session. Dear delegates, thanks a lot and good night.
Thank you, ma'am. Good night.
Yeah, thank you. Good night.
Thank you.
Good night. Good night.